And on to introductions for this next phase. I am standing behind Dr. Kathleen Neville, professor of nursing at Kean University. Again, we're going to keep the introductions brief because I could say much about each of these colleagues, and that would rob us of time to speak with each other. Next, I'm standing behind. I should mention that Dr. Neville will be speaking on
Psychosocial issues.
Psychosocial issues, so I don't have to turn my page back again. Thank you for that. On barriers to supportive needs and services, Julie Larson, Clinical Coordinator of Young Adult Services for Cancer Care of New York, and thank you also for being with us. We have such wonderful panels this afternoon. I would love to spend time with each of you individually. That would be greedy. And we have Dr. Regina Cunningham, the Chief Nursing Officer for the Cancer Institute of New Jersey, who will speak to us on survivorship. And so let us begin.
Thank you very much. I am a professor of nursing, but really have to introduce myself because it is so relevant to this topic of today and really keys into my perspective of adolescent and young adult individuals with cancer. I promised Anne-Marie, my background is in adolescent oncology. I promised Anne-Marie that I would focus on the young adult. And basically, I need to speak about lifespan development and human development because while we can very, very clearly identify the beginning of adolescence, there is tremendous blurring. I could remember many, many conversations I had with administrators in healthcare facilities about when does an adolescent become a young adult. And from my perspective, from a nursing perspective, it wholly depends on where one is in the attainment of the developmental tasks. So much of my experience that I talk about, and when I speak to this report that basically shocked me tremendously last weekend, I have all these notes. The report, even though I have published and I present about adolescent and young adult oncology, the findings were markedly surprising to me. We have so much work to do. The need is absolutely so tremendous. So basically, when we talk about, I began my clinical nursing experience working on an adolescent oncology unit. Clearly, I was educated and oriented in my professional work to believe that adolescents and young adult, thank you, Anne-Marie, is a very unique developmental time span. They have very unique special needs, different than a child, different than an older adult. And the difficulty with studying and caring for this age group really relies on there is so much variation among the stages themselves. A young adult at 21 is very different than a young adult at 39. We know that. What I have found in my research of adolescents and young adults is when we speak about attainment of, attaining developmental tasks, some of the psychosocial issues that I see survivors dealing with is that they're in their late 20s. They were diagnosed at 21, and they didn't develop a substantial partner relationship. So years later, they're still struggling. But someone who's 25 who maybe does. Someone who has a career going at 35 and is diagnosed is very different than someone who just graduated college and now has to face the stigma of illness and all the job-related difficulties. So where you are, not only in, whether it's an AYA, where you fall in that chronological age span, as well as developmental perspective makes all the difference in the world, and their needs are very specific, not just based on chronological age. So judging by just chronological age really poses some difficulties in helping people. When we look at the tasks of young adults, think about how much variability this is. And what my research and my work really has focused on is how the impact of cancer dramatically impacts on where they are in their developmental time span, because that affects their life. So in early young adulthood, you have people trying to gain independence from the parents, moving out. Think about while it's a young adult, a person may be 25 years old, but living in New Jersey with our housing market, and, the attainment of educational level in New Jersey, it's one of the highest. People aren't really moving on in their phases, development, even though chronically they're at their age, developmentally they may not be. But what this report really showed is that there are striking probably I would estimate after reading this, the need for young adult research, the need for unique specialized treatment for young adults, and what was discussed earlier, the need for research specific to the biology of the young adult and adolescent tumors is remarkable. It was so spellbinding to me that tremendous knowledge is needed in the non-Kaposi sarcoma, yet osteogenic and Ewing sarcoma is something that in an adolescent and young adult population you see. So this report is just absolutely mind-boggling. So basically, what I'd like to talk to about the highlights of this report. I encourage you all to download it and read it, but I'm just going to give you, I probably have 5 more minutes, right, Barbara? Okay. Oh, 7. Okay. The highlights of the psychosocial issues and this is what I knew, is that the empirical literature is very limited regarding the psychosocial outcomes, causes, and correlates for patients and survivor. I will venture to say I have researched adolescent oncology. I've spent my doctoral dissertation, I've spent probably 8 years of my life researching that. I would venture to say that young adults, there's an even greater paucity of research. I didn't realize until reading this report how much of an anomaly I am. I searched for literature in adolescent oncology. It was my doctoral dissertation. I searched across the country. I contacted people. The search was relentless. But what was even more important was to actually get the statistics of the incidence. It could not be distinguished. Young adults could not be distinguished from adolescents. I could get the pediatric statistics very, very easily. I could get the older adult, but the adolescent and the young adult literature, I had tremendous difficulty in getting the actual statistics. It's really only through this report that I think it is obtainable. Okay. The one very positive thing is that the current research trends that we use in pediatric oncology can certainly be used in the young adult population. When we look at most of the research that's been done in peds, really uses stress coping frameworks, and so much of the literature now highlights the post-traumatic stress disorder. We can use these frameworks certainly in the young adult population, using a family systems approach, because we know in adolescents and young adults that families are the most important support mechanism for helping them be diagnosed, living through, beyond, enduring cancer. I said it backwards. The PR group in this report really identified the need for assessment of psychosocial behavioral assessment across six dimensions to really formulate interventions. And the first one they really dealt with, and this was rather surprising, was that it dealt with intellectual issues. And this was surprising because this report really highlighted that young adults, they're beyond the stage of adolescence where adaptive denial is no longer in place. They no longer think they're as invincible. They do not deny their disease as much as adolescents. Yet this report really highlighted that they lack very important information. AYAs lack critical information about their disease and about their treatment. This report even went on to say is that they lack fertility knowledge about how their treatment will affect them and what options they have. This is major information that we just assume people are providing to people. Interpersonal issues, which is an area which my research has dealt with, relating with peers and health professionals is an important aspect of living with cancer. Communication, I identified this in my research. Communication may be very altered. As part of the trying to emancipate from parents, communication may become very altered with parents. All the research in pediatrics and adolescents and young adults does show that individuals living with cancer use protected communication with their parents. They don't want to traumatize their parents. They know they're upset enough, so they hold things with them. So there's a real dyad of protective communication. Family is the most supportive during the illness. It is painful, the qualitative research that I've done, to hear of survivors' reports of how they've been stigmatized in this day and age, of how they have been socially isolated, that they get tons of support during their initial diagnosis, but a year out of the network, friends, they are tremendously stimulated. They all report trying to catch up on their social relationships. They're losing valuable time. I would venture to say this is the most valuable time of of your life. Think about your own young adult. Many of you look like you're young adults. I'm a little beyond that. But it's a major time. Many of the things that carve the way for your future are here. Another thing that many AYAs are afraid to do is they're afraid to plan out the possibilities of their future. So they're on hold, because they don't know what's going to happen with them. They're living with uncertainty. There are many emotional issues. They're changed. They're different. They're not like their peers. I wrote a book on mature beyond their years because they're way over. And they basically feel very, very different from others, which is isolating. There are many, the report highlights practical issues. There are tremendous job-related stressors. There's discrimination, there's health and life insurance, there's a decline in career options, fatigue levels, they can't do the things they used to do. There are tremendous genetic ramifications. They basically, in the healthcare system, we've spoken about that, they don't know where they fit. They don't, are they in peds? Are they in adults? In my own research, adolescents, and they were young adults, they were up to 23 years old. They were more than 70% of my sample was accrued from adult clinics and not pediatrics or not adolescent. So they're all over the place. I had oncologists tell me that they didn't even know the numbers. They had no idea. They told me it would take a decade to complete my data collection on this age group, and it took 8 months. So the lack of information and knowledge we have is profound. There are existential and spiritual issues. Uncertainty is a catalyst for moving people on to a higher level. It can be very positive. We've all heard stories of people learning the meaning of importance of life, valuing things, taking things one day at a time. Lastly, I will just speak about the 3 priorities. I will be 1 minute. The first priority of this report for the psychosocial issues is really to develop and apply appropriate methodological approaches to better understand AYA health and psychosocial needs. All I can tell you, due to doing research in this area, is there are tremendous methodological difficulties. Much of what we study psychosocially, the measurement tools reflect psychopathological states. Individuals with cancer are not psychopathological. They are normal people dealing with tremendous stressors, and the tools should reflect that. So we have lots of methodological work to be done. Lots of psychometric tools need to be developed. The second priority is to improve training education to enhance healthcare professionals' abilities to deliver developmentally appropriate care and to enhance AYAs and family members' ability to be proactive in their healthcare. So we have lots of education and training to give to this unique population. And the last one would be to identify, implement, and evaluate innovative peer and family support intervention models throughout the continuum care, from diagnosis through treatment, off-treatment survival, and/or end of life. Just as an aside, in my research of many AYAs, it is more common than not to have them speak of their lengthy misdiagnosis. Many of them were ill for a year. Frequent cold, sore throat, strep throat. It took many of them, most of them reported that their delay in diagnosis was a significant factor, and they were largely affected by that. Thank you. Did I do it?
You did it. Thank you very much. I appreciate that. Moving on to Julie Larson, who will talk to us about some of the barriers.
Hello, I'm Julie Larson, and I'm coming to you today from Cancer Care, where I do the young adult services there. And also, and I know that many people have talked about the Progress Review Group, and I got this this report about a year ago and read it. And then in November, the NCI and the Lance Armstrong Foundation went together to form an alliance, the Young Adult Alliance. And I'm sure, Darlene, many people know about that alliance. But from the alliance, and this just was published about a couple weeks ago, was the strategic plan. And that was from the Progress Review Group, and now this is a strategic plan. So in addition to the priorities that everybody keeps talking about, I'm going to kind of also let you know what that alliance came up with as the plan moving forward. So you kind of know that and can apply it to what New Jersey's doing. When we think about supportive programs that are out there for young adults, I want to kind of, the barriers that we have, and certainly Kathleen already spoke to many of those, being that we really don't know what works. We don't have a way of testing what's out there. We don't know what is really effective, what is not effective. There's really not a formalized system of knowing, hey, is this really meeting the needs in the way that we want to? Do young adults feel like they're getting the information and support that they need? Do they feel like their questions are being answered? We don't know the answer. There are things that are out there, but nothing's really been tested. So strategy number one going forward is, hey, we need to create a system for testing what exists already out there. When we sat in the room down in Austin, Texas, and I was part of the group that was talking about supportive services, there began to be a bit of a debate back and forth about what is really needed. When a 20, 30-year-old walks in the room and hears, you've been diagnosed with cancer, what do they need next? And what we came up with and what's out there kind of clumps together into two main groups of support. Patient navigator programs, and that, if you're a professional in the room, you're a patient navigator. So a patient navigator program, and then the other clump is peer-to-peer support and networking. And there's a debate, hey, which is more important, which is more powerful, what do young adults need more of? And what we came up with is they are both important for very different reasons. And I'm going to talk about that. So as you listen and you kind of think about what New Jersey has out there and what you do as a professional, or if you are a young adult, where you went, these are kind of the differences for what's important between both of those types of supportive services. Patient navigator programs, usually the premise of that is to connect a newly diagnosed person to accurate, timely information, get them the information that they need on the broad range of issues. Education on their diagnosis, education on their treatment plan, and then those people that are doing that patient navigation to be very well versed, and this is kind of where we need to start heading and where we need to start going, about what's different about young adults. What are the issues that you need to talk about as a patient navigator with someone who's 20 or 30 or 18 that you don't talk about when somebody's 62? Information on fertility preservation and other options. Health insurance and financial resources out there. If you're in the middle of school, and where do you go if you need a medical single dormitory? What do you do if you need extended test times because you have chemo brain? What are these other things that young adults need that we don't think about? Employment rights. What are your employment rights if you're in a new job? Or if you're interviewing for a new job? Many young adults are in the beginning of professional development, and then you have to stop and take a break. How do you talk about that? Do you disclose? Do you not disclose? How do you talk about that? These are all young adult, very specific issues that as health professionals and patient navigators, we need to know about, and we need to be ready on a moment's notice to be able to talk about accurately. But we need to evaluate what are the gems out there. There are many of these things, and slowly with evaluation, we're going to know, hey, these are the gems of patient navigation, and you can even steer people toward those. Peer-to-peer support provides a completely different kind of support for young adults. But peer-to-peer support programs are designed to connect newly diagnosed patients with others who have been through similar experiences. This type of support is equally important because it normalizes the feelings of uncertainty, confusion, fear, feeling overwhelmed, angry, frustrated, sadness, and grief. These feelings are normalized when you get to talk to somebody else your age who has been diagnosed with cancer. In the young adult groups that I do, oftentimes that's the time when tips and tricks are shared, and we all know this. So all of that very, very helpful information about management of side effects, that's what comes through peer-to-peer support. So being able to connect young adults to peer-to-peer support. Developmental theory has shown us that actually adolescents and young adults are actually very, very respondent to learning from someone who's their same age. And so the ability to connect, and I sometimes think it's a benefit of mine that I am a young adult, and I know that that's something that I bring to this. I get many young adults that walk into my office, and the second they see me walk around the room and know that I'm in my 30s, we connect on a different level. So to be able to communicate with somebody of the same age is powerful. It's important. However, with that being said, and this is one of the strategies for moving forward, I've already talked about finding who are the gems in this, being able to evaluate the programs that are out there, what's working, what's effective. The second strategy is really related to peer-to-peer matching. And if we're peer-to-peer matching people, those young adults who are now survivors that are now talking to new diagnosed patients, they have the experiential knowledge, but they don't always have the training in, say, social work or psychology or different things like this. And so when they're hit with intense emotion, suicidal ideology, different things that can be very, very scary in crisis, they don't know what to do with it. So one of the strategies, while those peer-to-peer networks are out there and they're important, one of the things moving forward that we're thinking about is training and helping peers know what do they need to do, what resources do they need to go to when they're met with a crisis situation, when they're met with a type of support that they're unable to provide. So that's strategy number 2. Strategy number 3 is the development of standards. What does adolescent and young adult care look like? We've been talking about standards. Darlene talked about standards certainly in the beginning. We've been talking about standards throughout. What are the needs that need to be looked at? How do you do it? What always needs to be covered? Standards of care. And that is the same as true for supportive care. Strategy number 4 that came out was identifying indicators of success in current programs and increasing adolescent and young adult knowledge of their own diagnosis and treatment, decreasing isolation and fear, reducing distress, and increasing survival and quality of life for programs that offer supportive services for young adults. So one of the things they said is that, developing tools for evaluating, even simple just things within your own programs, before and after tests. What are you looking to find? What are you feeling right now? Test, post-test. How do you feel now that you've gone through this support group? Did it answer your questions or were your needs met? Really actually doing this, evaluating your program. If you've got a young adult program, evaluate it. And then strategy 5, providing opportunities for peer-to-peer support and awareness. And different than the peer-to-peer networking and the support groups that are out there online and the different things like that, also the ability to share your story. Broad platforms for sharing your story. There's talk about, cancer paloozas and different things to just really make this a place where people can actually talk about their experience and share it so that it's more of a wide range. People and the general healthy adolescent and young adult population are aware that this is something that could happen to them, and they can hear a story and listen to it because that has a powerful effect. So supportive. So that's all I have.
Thank you. Oh, I don't.
No, Regina, you don't need that yet. Thank you.
Okay.
Thank you so much. So much. We'll move on now and ask Regina Cunningham. Dr. Cunningham, give us some more information to take forward into our dialogue.
Okay, so I am going to be presenting some issues about survivorship in general, and some of what I have to say is somewhat of a call to action, so I want you to be thinking about some of these things as I go through. I only have 10 minutes to talk, so I've actually decided to focus on 3 key areas where I think we really need to direct some of our efforts. And those areas are in educating and empowering survivors and their family members, enhancing knowledge of survivorship issues among healthcare professionals, and some of these are going to sound like recurrent themes from what some of our other speakers have shared with us. And then I want to talk about advancing care paradigms through the development of knowledge. We need an organized and comprehensive research agenda that needs to be coordinated throughout the state of New Jersey. Again, as I'm speaking, think about the New Jersey picture and what are some of the things that we can be doing. So I'm going to start with the first issue of educating and empowering survivors and their family members. Many definitions of survivor include the family member, as I'm sure you know. We need to think about systematic approaches to preparing patients who are finishing their treatment and entering the survivor phase of their care, giving them what the American Journal of Nursing has called a prescription for living following their treatment. Patients, as we've heard, living with and beyond cancer have very special health care needs as a result of their illness. Many of these people experience the persistent symptoms that we've heard over from the different speakers, and we know that these can have a significant effect on function and on quality of life. So we need to address these. We recently conducted an investigation at the Cancer Institute of New Jersey. It was a multi-site study. We did it in cooperation with the Yale Comprehensive Cancer Center. And what we did in this investigation was talk to women. These were young women with breast cancer who were completing their treatment, finishing their chemotherapy. And we were interested in knowing what their experience was upon completion of therapy. What were their information and support needs when they finished their treatment? Interestingly enough, almost half of the women, 45%, reported that they did not receive any information on what to expect. We're missing the boat. Of those who reported receiving information, several indicated that what they received was inadequate. This is a quote from one of the patients. "If I had questions, they would answer, but there was really no closure to the whole process. There was a big difference between the briefing I got when I started chemotherapy, which was very thorough, versus when I finished chemotherapy. Part of that might be because we don't know all the things. We don't have enough data to support what we need to teach patients at this particular time. But almost all the participants stated that they would have liked to receive more information, and specifically more detailed information about what to expect. Many patients have described a feeling of sort of falling off the scanner when they finish treatment for cancer, and we need to systematically address how that can be made better. One thing that we've seen in the literature is that upon completion of primary treatment for cancer, that's been identified as a teachable moment. There have been several papers identifying that, that this offers us an opportunity to provide information to survivors on risk reduction, health promotion, and how they really need to manage their care throughout the rest of their trajectory. So capitalizing on this teachable moment opportunity in practice could help us to optimize the potential and ensure the delivery of high-quality care and influence outcomes for survivors. My question to you is, are we really capitalizing on this right now? I think at best it's only accomplished randomly, and we really need to establish processes within cancer care delivery systems that ensure that this happens in a much more systematic way. There's an increasingly compelling body of evidence that speaks to the benefits of certain health behaviors, including diet and exercise, in cancer survivors. Another question is, how frequently is this data being translated into practice? How much information are patients receiving about the evidence, although it's paltry? How much information are patients receiving about what we do know in these particular areas? So that's another issue, figuring out how to translate. We also know that patients need information on recommended cancer screening and other periodic testing, when it should be performed, and who should be responsible to do that. That all needs to be worked out. We need information on possible signs of recurrence and secondary malignancies, as we heard, information on many of the other effects of cancer, the marital and partner relationship, sexual functioning, work, parenting, potential future need for psychosocial support, information on the insurance issues, employment and financial consequences as well. Every cancer survivor, one of the big recommendations that's come out of these national reports is that every cancer survivor should receive a comprehensive care summary and a follow-up plan that provides information about their story. What are the details? What happened to them? That information, they need to have a summary of it, and that can be used to help to communicate what happened to other people. One of the issues that's been brought forth by the IOM is to try to make that document as succinct as possible. That's a challenge because the information that needs to be communicated is quite complex. So how operationally can we do this for survivors? How can we begin to think about accomplishing this? Another big issue is that we need to enhance the knowledge on survivorship issues among professionals. I was in a meeting yesterday, and one of the physicians that I work with said, you know, other physicians don't understand about survivorship issues. Although it's a relatively new construct, we know that survivorship care represents a distinct phase of the cancer care trajectory, and ensuring the quality of that care requires us to educate professionals. Again, we've heard a lot about this. One of the fundamental reasons why I think it doesn't happen is because people don't have enough information. The American Society of Clinical Oncology Committee on Cancer Prevention conducted a recent survey, which is actually unpublished, that asked, to what extent do you provide general medical care, including health maintenance, screening, and preventive services, to the cancer survivors in your practice? Only 31% of oncologists said they do that always. That leaves a big number of patients uncovered there. Several studies have indicated that family physicians are very interested in the issues confronting cancer survivors and would prefer to have a more active role, but they don't know what to do. They're looking for information. That's an area where that survivor care plan could come in very handy. The Institute of Medicine, again, has made some recommendations about what essential survivor content is. We need to look at that. How can we assure that New Jersey providers have that information? What kind of educational strategies do we need to think about to meet the educational needs of these diverse groups of providers? The second thing I want to talk about is advancing care through the development of knowledge. Perhaps it's one of the most important areas, and I'm certainly echoing what I've heard other speakers say. We can't educate, empower, or advance the care paradigm if we don't understand and expand our current knowledge base on survivor issues through research. Some of the key areas that we've heard about are late effects. The social and quality of life focus is quite important. The effects of cancer survivorship on the family, I think, is a very, very understudied area and a key area, particularly in this population. Another area where I think we need to make strides, and we've alluded to it a little bit today, are in models of care delivery. What are the best ways to take care of cancer survivors? We see specialists taking care of cancer survivors, generalists, a combination, shared care. Little is really currently known about the type of care that's provided to cancer survivors in the primary care setting or patients' perceptions of that care. We know that the U.S. cancer care infrastructure is currently not prepared to provide quality survivorship care to the growing number of cancer survivors in this country. It's anticipated that oncology specialists will play an important role in the design of systems of care addressing the follow-up needs of survivors, but it is not feasible for them to deliver all of the care that's going to be required. Because of the diverse needs of cancer survivors, their care is going to require the expertise of a variety of professionals who will have to work in concert on their behalf as they traverse the treatment trajectory. Cancer care needs to be reconceptualized along a continuum that spans from prevention through survivorship, as Darlene mentioned. As individuals navigate this continuum, diverse providers will need to render care. An issue that's going to come up with this sort of reconceptualization is managing transitions between providers and settings. Transitions between care settings are complex, multidimensional processes that are going to require closely fitted communication between groups in order to avoid what the Institute of Medicine calls quality chasms. Sometimes quality chasms occur when organizations are right across the street from one another. We have to figure out a better way to do this for patients. The issue about PCPs, which Jenny brought up before, I just want to highlight a little bit. The IOM report, again, talked about the importance of incorporating PCPs into this whole care paradigm. They may be optimally positioned to provide many aspects of care for survivors since they operate from a comprehensive perspective and are typically the guardians of general and preventive health care services. Several studies have documented that recurrences often develop between regularly scheduled oncology follow-up appointments, and patients frequently present to the primary care physician when they first notice symptoms. We at the Cancer Center, we're connected to a New Jersey Family Medicine Research Network, and we've actually looked at the survivor population within certain practices, and we found that we have a very high number of cancer survivors who are receiving care within that setting, much higher than the national average. So New Jersey has some opportunities, I think, to really look at the primary care connection and the specialty connection. Another issue is that approximately 70% of survivors have comorbidities. Now, that may not be as true in the young adult population, but we don't really know because we know that they can have special issues related to their disease. So that's something that I think we really need to look at and we have to factor into the equation. How can we do a good job with this? Another issue is the cost effectiveness of models of survivor care. What about the research agenda on survivor issues in the context of diverse populations? Again, New Jersey's got great demographics. We have an incredibly diverse population and a wonderful opportunity. Another issue is when you think about those wheels that Betsy showed us before, a lot of the research that's been done on survivorship has been focused in specific disease entities. We need to broaden that. We need to look beyond the diseases that have been well studied. And if you look at the NCI survivorship office portfolio, you'll see that most of the funding has been in the area actually of breast cancer. So we have to think about expanding that agenda and building the research in other areas. So I think that we have a lot of opportunities, many of which are very unique to the state of New Jersey, and we need to think about that as we begin our dialogue. Thank you.
Thank you. And to the whole panel. I am extremely grateful. All 6 panelists have done a great job of helping us save and secure time to be with each other.